if you have some symptoms that a lot of people have, that means it's common. It doesn't mean it's normal.
Yeah. Period.
Yes.
Period.
Crushed it.
And here's the thing. We all have good podcast voices.
And good hair. Welcome to Pelvic POV with your hosts and doctors of physical therapy, Amanda Neary and Hannah Meyer. Hey, pelvic freaks. Welcome back to another episode of Pelvic POV.
We're your freaks for us and we're freaks for your pelvis, baby.
And welcome to Pelvic POV, Dr. Rahman. We're so excited to have you.
Thanks, guys. I'm looking forward to it.
Oh my gosh, we're so excited because you're actually the first MD we've had on our podcast and you're so close to us.
I know, literally down the street.
Literally down the street.
We just realized that our practice is less than half, like 5 blocks away from each
I know.
other.
It's amazing to be another local Chicago provider.
Yes,
this is like
absolutely.
our dream to have as many of us on the pod as possible.
And especially for our first guest, so we love it.
Wonderful. So excited to be here.
Just a little background on Dr. Rahman. She is a sex med gynecologist, a menopause specialist, and the founder of the GYN Sexual Medicine Collective here in Chicago. And she specializes in menopause care, sexual dysfunction, sexual pain, genitopelvic pain, menopausal hormone therapy, and much more. So, Dr. Rahman, can you just give us a little background on how you got into your specialty and what it is you're doing these days?
Yeah, absolutely. Well, I started, as a general OBGYN, board certified, and I was working in the academic medical centers for the first probably 7 or 8 years of my post-residency period of time. And so when I moved to Chicago after I got married, that's what I was doing. And then at one point I was working sort of crazy hours, and, my husband's like, it feels like your personality's kind of changing because I wasn't sleeping, obviously. And he's an interventional pain sports medicine doctor, so he had started his own practice in 2013, and he had built out this space, and he's like, why don't you start your own practice? And I was like, okay, that's what people learn how to do in medical school. Like, nobody knows how to do that.
No,
right?
yeah.
It's really difficult to actually understand and kind of do the nuances of starting a practice from scratch, especially if I'd been an academic. So I did, with much turbulence, because nobody was really at that point willing to even give me guidance or anything. So I did it kind of on my own, and I failed miserably for a very long time because, in terms of coding and billing and all this stuff, I just didn't know how to do it. But what it gave me was the opportunity to go from seeing 40 patients a day to 10 to 15 or, even 15 to 20, half the number that I was seeing. And with that, especially in the first few weeks of my practice, as you're building, as people don't know where you are, I started seeing patients with really complex issues. And it was a GYN only practice, so I wasn't doing obstetrics, and I stopped doing it totally at this point. But I remember one of the first patients I had was a midlife woman who had sexual problems, and this was back in early 2014, before they even had words and definitions to describe it other than vulvovaginal atrophy. And so I was talking to her, and I had all the time in the world because I just didn't have a big patient load. It was my first week as a private practice doctor. And I gave her all this time, and I was like, wow, this is really great that I could really get an understanding of what's happening to her. But then I realized I never learned how to treat a lot of this. We had terms like vaginismus or vulvovaginal atrophy. Again, this was almost 11 years ago now. So I was like, how, what am I going to do? I gotta figure out how to help this lady. So then I started doing a lot of my own investigative work, and I joined the Menopause Society and became menopause certified, did all the coursework and started really diving deep into the literature. And then I actually started with the Sexual Medicine Society of North America, SMSNA. And I went to my first conference and was hoping to get the scoop. And I realized it was all penis. It was all, It was urology mainly. And a little subset of women's health. I was one of the only gynecologists there. But at that time I met Dr. Irwin Goldstein and Dr. Rachel Rubin, who, Irwin Goldstein's the godfather of female sexual medicine. And he was like, you need to join ISHWISH. And so then I did, which is International Society for the Study of Women's Sexual Health. So I joined that, and I did the coursework, and I did a mentorship with him. And I really got to the bottom of some of the issues that, we didn't learn, or that some of this is brand new information in the past decade, that was way past when I graduated from medical school and residency. So then the more I did, the more patients like that I saw. And over time, it's just this is my expertise now, because I've been doing it exclusively for, 11 years now. And so, now I'm educating other clinicians on how to do it. So I'm on the board of directors of ISHWISH, and I'm the scientific chair, but I'm also like a faculty for the fall course, and I've implemented it at Northwestern as well. So we're doing some sexual medicine, problem-based learnings for third and fourth year medical students, and teaching them menopause management, and they rotate with me. And so I'm trying to, undo what hasn't been done, which is like a generation of doctors that never learned how to do any of this. And so I have actually a lot of clinicians that come through my office and rotate. I have people from all over the world come in, like medical students wise and everything, and they come learn from me as well. So it's been a journey, but it's been a lot like, you have to actually have the initiative and the desire to continue to learn. And this is something that every time I go to an ISHWISH conference or a menopause conference, I learn new information and bring it back to my practice. So it really keeps you on really your finger on the pulse of sexual medicine and menopause. And it's really been a passion of mine too.
Yeah, that's amazing.
Yeah, so it's been cool.
We talk about how, like, when we got into pelvic floor, it opened up a whole new world of physical therapy for us.
Absolutely.
And you just feel like the more you know, the less you know, in a way.
True.
And there's just so much to constantly be learning.
Yeah.
And
every patient you learn from too, like every time you
Yes.
get a new patient that has something and you're like, wow, I never thought about that. And maybe there's a link between this and that. And then you talk to other clinicians, they're like, yeah, I've noticed that too. And that's how research gets done too,
Yeah, it's amazing.
Yeah.
Oh, that's so true. You had so many good points in just that little blurb that you put out right there. Like,
I talk a lot, sorry.
Oh, no. I love it. I do too. I'm the same way. But I think first off, you opening your own practice, it's similar to us with pelvic PT. Like when I started, I was at like a corporate, more like all kind of areas of PT, like ortho clinic.
Yeah.
So I would be getting pelvic floor patients because that's always what I've been wanting to treat. But then I would have like a knee patient at the same time. And then like right after that, I'd have a shoulder. And then I'd have like my patient with like vaginismus. And I'm like, how am I supposed to treat these patients all at the same time?
Right.
My care was not as great. And then I was treating like 15, 16 patients a day for like PT versus now here we treat like 7, maybe 8 a day.
Yes, exactly.
And full hour sessions, like one-on-one. And the care that we can give our patients is just astronomically different. And also like what you said, what I learned from my patients too,
Right.
just by the conversations that I'm having for that full hour session.
Yes.
And being able to apply that to more sessions with other patients.
Absolutely. And, we all know that the field of sexual medicine and menopause management is really about more than one discipline, right? That's why we say in sex med, we say it's a biopsychosocial approach, right? We need the biology treated with, different clinicians. PT's always involved. I feel like there's never been a sexual medicine patient that hasn't needed PT from me, but most of my menopausal women do too. And so it's interesting that, and then you have the sex therapy and you have psych and you have all the other aspects of really approaching it through a multidisciplinary biopsychosocial approach. And I think that's what's so important is that, we have respect and collegiality amongst each other. And so that's why I love working with PTs and psych and or psychologists and sex therapists as well, because it takes multiple people to get a patient to where they need to be.
Oh yeah, that's why I'm excited to learn about ISHWISH too. When you
Oh, yeah.
brought that up today, because I feel like we're going to learn so much from you and from all of the resources you've already given us.
No,
for sure.
Yeah,
And
we're
I think-
sold on it already.
Yeah, it's your people for sure, because it is very much, a third of it's pelvic floor PTs, a third of it's probably, in psychologists, sex therapists, a third of it is like MDs of all variety or PAs or nurse practitioners, DOs, the whole thing. And it's just like really, and then we have patient advocates. We have, so that's like people like from Tight-Lipped and organizations that are really about, raising awareness about their own conditions. And so I think it's an amazing organization. And I really recommend anyone that treats in sexual medicine to be a part of it.
Yeah.
Yeah.
I also think it's amazing that you mentioned how much time you spend with your patients. We've had a couple sex therapists on now, and we'll frequently talk to them about how long it takes to build rapport with this patient population and how we really need that full hour, which is why it's so hard for us to treat at clinics that aren't specialized in pelvic floor. But I think a lot of people have the preconception that when they go to their doctor, they're only going to get them for like 15 minutes or so, and they don't know what else they're getting. So you're giving that individualized care that your patients need, and I think that's incredible.
And I think it speaks to actually being in a non-traditional healthcare model most healthcare models are dictated by insurance companies, and they're dictated by, private equity or a large hospital-based program that really pushes numbers. And so when I worked for big academic centers, I was supposed to see 30 or 40 patients a day. And so when a patient told me at the end of my visit, hey, by the way, I don't have a desire to have sex anymore, or hey, you know what, I'm having a lot of pain on insertion, and I'd be like, oh my God, I have 15 patients waiting, and I have this poor lady has this huge issue that really takes, we call ourselves sex detectives in the Ishwish world, right?
Oh, that's awesome. Yeah, I like that.
Because we have to really look into all the aspects that are affecting it. And I'm just like, it was very frustrating in that system. And by no means will a normal healthcare system really allow for that unless, you're in a fellowship program or something that's pushing for it and pushing the narrative. But you still have to be able to give them, produce the money that they need to keep their practice open, right? So that's why I actually had to move out of the model, because I had too many impediments with insurances.
Insurance is a hassle. We're a hybrid practice now, but even working with one insurance company, it has its faults at times.
Yeah.
It's nice to have the access, but we still have to work within their parameters.
Right.
So we had to be very picky about what companies we would work with.
Absolutely.
In that regard too.
Yep.
All right.
And then it's like they're dictating the care for the patient, not the
No,
actual
literally.
people seeing
Absolutely.
the patient. It's like, oh, now I can only do what the insurance tells me I can do.
100%. I have postpartum women come in all the time, and we're treating them for sexual dysfunction, or maybe it's pain with intercourse, or maybe stress incontinence. But then they come in one session and they're like, I'm having so much upper back pain because I'm breastfeeding all the time. And it's well, technically, if you're following the insurance model, then we have to do a new evaluation and treat this new body part versus if you're doing just an out of pocket outpatient holistic, we're going to treat that alongside your pelvic pain, and it's really all connected too.
Right,
but insurance doesn't understand that.
Right.
Yeah.
I mean, we know that women that have hip labrum tears and radiculopathies in the lumbar sacral spine also have pelvic floor dysfunction and vice versa, right? So it's not a vacuum treatment, and that's how they approach it.
Oh yeah. And I've had a I'm thinking of a specific case of a patient with endometriosis, and it's a more chronic pelvic pain condition that we're treating over time, but we lost insurance coverage, and we only get approved 4 visits over time, 4 visits at a time. And we have to show progress within those 4 visits, or we don't get more approved. And it's and then they don't take pain with intercourse as something that needs to be treated.
Right.
So it's what do I literally sometimes I get off the phone with insurance and I'm wanting to pull my hair out. It's
absolutely.
crazy. But
and then the number of times you have to call and get, pre-authorization or pre-approval.
That takes an hour, and I have to do it over my lunch, and then it's you don't even get lunch that day, but it's at least we're getting care for the patient now.
It's so frustrating.
Yeah.
I totally agree with you.
Yeah. People are like, what's it like working for yourself? And I'm like, well, I work for Blue Cross Blue Shield, actually.
Yeah.
Don't actually do that yet.
Exactly. Because it's probably the only industry that you can provide a service and you may or may not get paid for it.
Totally.
Right? My first 3 years of private practice, I would provide services for United and all the insurance companies. And I had maybe a 60% payer rate, meaning that 40% of the time I didn't get paid for services that I provided. And some of it was me not understanding the nuances of how they wanted to bill it. But other times it was no, they didn't agree with, for you providing that service. So free service.
Yeah.
It is wild.
It's crazy. It's inspired. You both inspire me with literally going against the norms and then opening up your own practice. I wouldn't be able to do what I do unless you opened your practice. So it's really
We got something
great.
good.
You guys are great.
Yeah, absolutely.
We're out here. But yeah, one more frustration. They pay PTs less per code now than they did 20 years ago.
Absolutely.
It's going backwards.
Right. We're the
It's
only
wild.
field that doesn't get inflation in our favor, right?
Yeah.
They'll just start decreasing payments, or they bundle them. That's the best, right? All of a sudden everything's bundled under one code. For OBGYNs, for obstetrics, your whole payment includes 10 visits postpartum, when they round on you in the hospital, and the whatever delivery. You get one payment for all that.
Wow.
So it doesn't matter how many times you pay the patient. How many times you see the patient, you won't get paid extra for that. So you have to do everything within that one bundled system.
Wow.
And sometimes they won't, if you see someone for an extra postpartum, not included, they won't pay for that.
Wow. I did not know that.
Yeah, it's a
The
they
joys.
call it global fees.
All right, so you figured out the best system, which is concierge practice. That's amazing. Can we get into menopause specific care a little bit.
Absolutely.
Because we've talked about this from the pelvic floor standpoint with tissue elasticity and some things that we'll see in perimenopausal patients. But from the medical standpoint, we've never really gotten into it, especially on the podcast. So I think it'll be really beneficial for our listeners just to hear like what are some of the symptoms you're typically seeing and like maybe not what they're thinking of.
Sure.
What comes first to mind.
Sure. And I think, when it comes, we can start with the pelvis and then go systemically, because there's just a host of symptoms that women experience in the perimenopausal transition as well as in menopause. So menopause by definition, 12 months without your cycle, average age is 51, and that really counts for mostly white women. Women of color tend to hit menopause earlier, and that means the perimenopausal period can start earlier. And that perimenopausal period can be 7 to 10 years of this roller coaster of estrogen going up and down. And as your progesterone kind of goes down, more consistently. And so what happens is, let's talk about the pelvis first of all. There's a syndrome called the genitourinary syndrome of menopause, which, by year 6, over 85% of women have this, meaning year 6 after the final period. But in that transition, a lot of women can have a lot of the symptoms of it. And so this used to be what was referred to as vulvovaginal atrophy. But in 2014, a bunch of urologists and gynecologists and menopause experts came together and said we need a better term to describe it, which included the urinary system, because we know that it is hormonal dependent. And so as we lose estrogen and as we lose testosterone, because our ovaries make 50% of our testosterone, women develop this genitourinary syndrome of menopause. And it's not specific only to midlife women, which is interesting, and I'll talk a little bit about that in a second. But what it is where when you have these deficiencies in these hormones, you have issues around urinating, so you can get pain with urination, you can get frequent urination, and you can get that urgency, gotta go. And then also worsening stress incontinence if you already have it, because you're losing that elasticity of the pelvis from estrogen, which modulates a lot of the collagen production. And so you get these urinary symptoms, and then you have this impact on the vulvar vestibule, which is that little slither of tissue at the opening of the vagina. Just like a vestibule, you have to walk through to enter a big room. You have to cross the vestibule to enter the vagina. And so this tissue is actually more consistent with the urethra, and it has estrogen and androgen receptors, which means it means that it needs both hormones. And so when you're losing these hormones, the area becomes red, inflamed, angry. And as you know, the pelvic floor is so intricately linked that as you start getting vaginal dryness is one of the symptoms, because estrogen also impacts your vaginal microbiome and your vaginal pH. So when your vaginal pH goes from acidic to basic, you get all these changes and lack of lubrication and more dryness, right? So dryness is one, painful sex is another. And then it just sometimes is irritation or vulvar irritation or irritation at the opening of the vagina. So we have that issue with the vestibule. We have lack of elasticity in the vagina and lack of a normal pH, which makes you more susceptible to UTIs. So a lot of women get recurrent UTIs in the peri and postmenopause. And when you're getting recurrent UTIs, you think that it's a benign condition, but we know that UTIs kill women, especially as you get older. You can get septic from these UTIs. And so this syndrome isn't just about sexual comfort, and it's not just about vaginal dryness. It's about urinary tract infections that can kill women. And so what we know is the use of local vaginal estrogen therapy or local vaginal DHEA can treat this condition and reduce those risks by 50%, at least the risk of UTIs. And we know that we can get patients pain-free with sex when we use these hormones plus pelvic floor PT. Because as you know, that as you start feeling irritation down there, you're going to clench your jaw, or you're going to start clenching your pelvis, and you're going to get that high-tone pelvis. So that, is the genitourinary syndrome of menopause. I know you guys see it a lot too, because people get sexual pain and pelvic floor dysfunction from it and high-tone pelvis. And so it is an intricate part of the treatment, I think, pelvic floor therapy, using pelvic trainers. I use vaginal Botox in my office too for people that have vestibulodynia or pain at the vestibule from just high-tone pelvis issues. And so I use that in coordination with pelvic floor PT. And so there's a lot we can do, obviously, but that is one of the symptoms that you can experience in perimenopause. But there's also obviously hot flashes that you hear about, night sweats. Those are the vasomotor symptoms, or generalized heat intolerance, like you're just hotter than everyone. I always ask my patients, if you put the temperature at 60 degrees, are you the only one not wearing a sweatshirt? And usually they are. There's that temperature disorder, there's a lack of sleep, there's weight gain associated with it, there's a whole musculoskeletal syndrome of menopause because of the lack of estrogen at your joints. and how it affects your bones. So it's a full body situation, and that's why more than gynecologists and more than urologists should be learning about menopause, because it affects people in orthopedics, it affects your lumbar sacral spine, it affects everything, right? So it is really a multidisciplinary issue.
I like that you brought that up, because especially hot flashes, because I feel like the only thing that people think of when they think of menopause is hot flashes, and they don't realize that it can be so much more than that.
Yeah, and actually the probably the number one symptom I get from a perimenopausal woman is actually more around their mental health. Like they say, I just don't feel like myself. That's the number one symptom. But a lot of it is new onset anxiety. I can't fly like I used to. I get anxious going behind the wheel of a car. They have new depressive symptoms. Or quite frankly, they're irritated as hell. They're just pissed off all the time.
Yeah.
And it's because our hormones modulate our neurotransmitters in our brain, right? And so as we lose estrogen and testosterone, we're losing that function in our brain as well. So there's a cognitive issue too. Some patients tell me, oh, I thought I was getting ADHD, or maybe ADHD was being revealed because we don't have the hormones modulating it anymore. You can't be as high functioning. Or imagine like being in front of a boardroom giving, a pitch to somebody, and you forget what you're going to say in the middle of it. This is why menopause has menopausal women and perimenopausal women leave the workforce a lot too, because all of a sudden they're not thinking the way they used to. They're having cognitive deficits. They think they're getting dementia when this is just all related to this estrogen losing in your brain, loss in your brain.
Wild.
Yeah.
And it's something that's just brushed off. It's like, perimenopausal. That's just
here, take your antidepressant. And
I feel like our generation has brought up talk about mental health a lot more than previous generations.
So you guys Z or millennial?
I'm millennial.
I'm technically a zillennial, I like to say.
You're at the cusp.
I'm at the cusp.
You're at the cusp.
I'm at the cusp. So I take the good parts of both generations, and I'm
Yes,
like,
she
that's me.
She's the best blend of both of them.
That's what I like to say.
I like to say I take the best part of X and the millennials and kind
There
of
we go. Exactly. So you're cusp too?
sort of.
Yeah, okay, cool.
I'm probably more X, but I feel like I relate to the millennials.
Okay.
But yeah, I think it's interesting because people are writing about it more, and women want to know about menopause more too, right? Because they come in and they're like frustrated because someone said they're too young to go through perimenopause. And so perimenopause doesn't mean you can't get pregnant. Perimenopause doesn't mean you still can't have a family, but it might mean you have to tweak your hormones a little bit, or change your lifestyle, or do something different in your life to get you through it, so that you're not just dealing with sleep deficits that can affect your cardiovascular system, or put you at risk for diabetes. All of these things that we know that can happen, and we know that the number one reason women still die is a heart attack. So we want to make sure that we're doing preventative things up front.
Is there a symptom-specific range where you would put someone in perimenopause versus menopause, or is it just based on age?
It's based on their menstrual cycle, unfortunately. Okay. So, we think that because sometimes women's cycle starts to become a little bit irregular initially in the perimenopausal transition. So I always say early perimenopause, some people might notice that they went from a 28-day cycle to a 21-day cycle, whereas in late perimenopause, you start skipping cycles. But because of the confusion around it, and there's so many factors that go into it, right? Do you have autoimmune conditions? Are you under a lot more stress? Like what's happening with your fertility? All these things that we know that can impact, kind of when you might go through perimenopause. And again, race and ethnicity have a huge factor to do with that as well. And so we look at all of these factors and parameters. But if you haven't technically had 12 months without a period, you're still perimenopausal.
Gotcha.
But what we know is, if we started to track hormones in someone that, say, has an IUD that doesn't menstruate, or has an ablation and has not menstruated, or someone that, has had their hysterectomy and they don't have a period anymore, then we can maybe track hormones to see, when their levels are consistently more menopausal than not. But we don't have a great way to otherwise. It's clinical. Perimenopause is a clinical diagnosis.
Yeah. Okay. And you talk a lot about different demographics, which I actually had a question on. Do you feel like the research around this is comprehensive, or are we just completely lacking in this area?
In terms of ethnicity, racism?
Yeah, and just when people
I think in general, midlife women research, sexual medicine research is lacking big time. If you look at the number of, say, women that get in clinical trials, we know there's less women, women are not small men. It wasn't until 1993 or was it 97? 93 that women were allowed in clinical trials. So it's not like it was, hundreds of years ago.
Right.
Like it was literally within, the last, 40 years or something, that women were allowed to be in clinical, or, were allowed to be in clinical trials. And so alarming to think that up until then we were just treated like small men, or everything was based on mice studies, right? But I will say that I think that, now with all the loudness around midlife, more money is being put into menopause research. There's a lot of misinformation about menopause, out there circulating. But I think that also it's harder for women, like when you talk about women of color, there is still a dearth of research on women of color. And I think that a lot of that is due to like historical distrust of the medical community, but also lack of ability to really recruit them. Like either you're not looking at that demographic, you're not trying to recruit that demographic, or, that demographic doesn't want to be included because they don't trust the medical system.
Absolutely.
Because of the history of our country,
Yeah,
and
absolutely.
systemic racism. So.
We actually just reviewed a new systematic review in pelvic floor postpartum interventions, and we were talking about on that episode how profound it is that we even have that because it's just so limited and
fourth trimester is so ignored.
And we're like, okay, this is cool that they even have a new systematic review that came out this year, and then that's just looking at like women as a whole. Like there was no demographic divide within any of that, so it's interesting to see, like we are getting more research, but I feel like we still need to play a lot of catch up, and
Absolutely.
there's so much more that needs to be done.
Right. And speaking of fourth trimester and postpartum, when we talk about the genital urinary syndrome menopause, I'm sure you guys see this all the time, but there's now sort of a genital urinary syndrome of lactation that we have identified. But what we've known for a long time, that this hormone deficiencies and hormone dysregulation, I guess I would say, that happens, that affects the genital urinary system, either the vestibule, the urethra, the pelvic floor, the vagina, isn't just about midlife women. It's about postpartum women who are lactating and their estrogen declines. It's about women who go on birth control pills and their natural hormones are suppressed, and then all of a sudden they don't have enough estrogen or testosterone to feed that vulvar vestibule. And it's about women who have had cancer treatments, who have had their hormones suppressed. So it's and people that get fertility treatments, right? They get a sort of temporary suppression of hormones too. So it's interesting that some listeners might think, oh, well, this is not going to affect me, but I would think twice, because I see 20-year-olds, Gen Zs themselves, who come in and say like they have sexual pain, and it's not all related to the pelvic floor. It might be related to the way the nerves have proliferated in the vestibule. It might be related to hormone. We call it hormonally associated vestibulodynia, which is just a term to describe pain in the vestibule due to hormonal association. And the same can be done for neuroproliferative, which means nerve endings have kind of sprouted up in the vestibule for other inflammatory conditions that they might have. So it's very detailed, I think, in terms of pain with sex is not always hormones. It's not always just pelvic floor. It always has pelvic floor involvement, but it's not always. It's usually multiple things are involved.
It's interesting to hear you say that, because we only really talk about treatment of pelvic pain or like pain with sex from a pelvic floor standpoint. So I'm really excited to hear you talk more about that. That's awesome.
Right. Absolutely.
What are your like typical treatments then, if it's like not just pelvic floor?
Yeah.
Like what's something that you'll do?
Well, so if it's hormonally associated, and remember I was saying the vulvar vestibule has a lot of androgen receptors, so it needs actually some testosterone. So I always give the example of like the 13 or 14-year-old girl that gets acne. And, the first thing, and she has an irregular cycle and she's an athlete. And so people are like, let's put her on birth control pills. And I'm not here to vilify birth control pills. I'm a gynecologist. I use birth controls all the time for people. But I just think it's important to understand, just like any other medication, what are the risks and benefits. And so when you have a patient that you put on this initially, and she may absolutely need it at that time, 10 years later she comes up having pain with sex, and a lot of people think it's just vaginismus or pelvic floor dysfunction, and you treat it and it's still not getting better. You can actually take a look at the vulvar vestibule closely and see if it's like really red and inflamed and angry. Have the labia disappeared? Is the clitoris shrinking down? Because this area needs so much more in terms of hormones than just estrogen and these androgens as well. So this is a time that we might use a compounded agent with a trusted compounding pharmacy, an estrogen testosterone cream or a gel that we would put at the vestibule that we apply. You have to kind of remove the inciting agent too. So we know that when women ingest oral contraception, especially, there's so many different types, that some of them are androgen lowering, and that's why they work for acne and hair loss and all the good things that we want. And you always have to meet your patient where they are, because some patients are like, I'd rather not have acne and have painful sex instead. So you try to get them to a point where they can feel comfortable with that, or maybe they change their acne treatment or whatever. So it's not always the solution to remove all birth control pills, but that is one of the things, is either changing the type of birth control, maybe one that doesn't have as much androgen lowering capability, although I haven't seen that clinically to be as helpful as actually removing it in patients who have hormonally associated vestibulodynia. So they will then remove the hormone, maybe take an IUD instead. So we know what happens when you take an oral contraceptive and it gets metabolized through your liver. You're increasing this protein called the sex hormone binding globulin, and that protein binds to your testosterone. And that's why it helps to really lower your systemic testosterone levels, and that's how it can help to treat, that acne and that facial hair loss kind of stuff, the high teeth stuff that we see. And so when you have them take a break from that and really apply the estrogen, testosterone, and then do it in conjunction with pelvic floor PT, they have a pretty good success rate for having pain-free sex. And that's one of the ways some patients that are postmenopausal or perimenopausal can also use vaginal estrogen and use a cream to apply to that area, or vaginal DHEA in the form of what's called by name intrarosa or prostrone. It actually converts into estrogen and testosterone in the vagina and kind of gets to the vestibule. So that's one of the treatments. If they have, some women are born with too many nerve endings at the vestibule. So you'll see these women who've never been able to use tampons. They've never been able to have pain-free sex. They've never been able to tolerate a pelvic exam. And so we think there's an association with this nerve proliferation. So they have too many nerve endings at the vestibule, basically. So the minute you touch them with a soft Q-tip, it hurts like hell. And so a lot of these women, can be treated with medications that will reduce the inflammation at the vestibule. So these women who have that, what we think have too many nerve endings, sometimes about 60% of them have umbilical tenderness or discomfort too, because the vestibule and the umbilical cord, your belly button actually have the same embryologic origin. And so it's interesting when you ask them, I have a lot of sensitivity at my belly button. I've never been able to use tampons. I've never been able to have a GYN exam. And of course they can develop vaginismus, which is that involuntary contraction, but the root of it may have been that they have too many nerve endings. And so when you treat them with pelvic floor PT and it doesn't get better, then we look, at the nerve endings to see, do we want to put a neuropathic pain medication topically? Find that people who acquire this over time and they're not born with it, so they went from having pain-free sex to painful sex because of some inflammatory condition they've developed. They actually can respond to something called capsaicin, which is, the active ingredient in hot peppers. And so it's
Interesting.
It's a hard buy, though, to tell a woman who's in pain to put hot peppers at your vulva.
Oh, yeah, for sure.
But, some of them will do it in a systematic way that I will sort of explain to them, an algorithm to do that, and then they'll do it, and then they can get pain-free with pelvic floor PT and capsaicin. But a lot of people need vestibulectomies. They need to have their vestibule removed, and that's sort of the end game. And then they need PT aggressively after that, correct? Because although the surgery in and of itself isn't as complicated, the procedure after the recovery, right? You're clenched for weeks after that. The pelvic becomes very high tone. And so then they need that. They need CBT because they've lived with pelvic pain for so long that they have to convince themselves that their pain is gone, even though their brain still thinks it's still there, So it's very complicated, I think, in that respect. And then we now know also that women who have inflammatory conditions, say they have endometriosis or PCOS or one of these conditions that we know have an inflammatory process, that they probably have abnormal mast cell activity, so we call it mast cell activation syndrome. And that's when, your mast cells are your first line of defense against, inflammation or, your immunologic response. And these mast cells degranulate a lot of factors, like growth factors. They degranulate nerve growth factors. And they're supposed to only do it when there's, they're supposed to attack something because, they're trying to protect your immune system and your connective tissue. But sometimes they just degranulate all the time, and so then they form these nerve endings at the opening. So if you look at sort of a vestibulectomy and the tissue, when you can stain it for mast cells and see a lot more in the high-powered fields than there should be. So we know there's that association. So there's been some studies, the latest studies that are being done are if we use a mast cell mediator at the vestibule instead of trying to go towards surgery, that's the next sort of area of research that we're looking at. If we use a mast cell mediator topically at the vestibule, are we going to get some improvement in symptoms? And that's kind of the next question that we have. Even when someone has deep infiltrative endometriosis and they have that tissue removed surgically, you'll see a lot of mast cells per high-powered field. So we know that there's like a whole inflammatory process going on there. It's so interesting. And I'm sure you see it too. Like a lot of people have endometriosis, they have mast cell proliferation, they have pelvic floor hypertonicity, and then they'll have something like POTS syndrome where they like pass out a lot, right? Or they have hypermobile joints.
Totally.
And so that's all related to, and we're trying to figure out the pieces of that puzzle right now.
You've described like an exact patient that I've had, like literally to a T. It's actually crazy.
Isn't that
like
crazy?
the exact patient presentation, like multiple times.
And it's funny because I think this is how research happens, right? Because some of us are like, have you ever noticed that these patients hypermobile have this or that? And then people start looking and, oh, let's look at mast cells and let's look at this. And then you see a connection. And what to do with that connection is always the question. But there are a lot of hypermobile experts that, you know, have different ways of addressing this and mast cell proliferation and all that stuff. So
I feel like mast cell activation is something that is now gaining traction for the first time.
Yes.
In like the past couple of years, I've been hearing more about it and
Yeah.
patients actually being diagnosed with it.
yeah, it's a hard diagnosis to get though. That's the problem.
Yeah.
Yeah.
That's what I've heard.
I think our listeners are going to benefit so much from hearing this because we have people that just go to pelvic floor PT or like their gynecologist will refer them to pelvic floor PT. They try pelvic floor PT and it doesn't work. And it's like, what now? It's
Yeah.
great to hear that there are limitless other things that
we're
can
looking
be done and that are still being researched for your care.
Absolutely, yeah. And I think, like, I always consider myself like, you know, like the orchestra person that's like trying to orchestrate. So I'm like, make sure you get to pelvic floor PT. You need to see a sex therapist. You need to get in with this psychologist that can use CBT or, you know, sometimes EMDR, some of these other techniques, because someone that has lived in pain their whole life can't just have the inciting agent removed and think they're going to be pain-free. Because, you know, we see this all the time. People have vestibulectomies. The pelvic floor is pretty good. They're, you know, they have no pain at the opening when you examine them, but then they still can't have sex. And so what's the missing factor? We have to treat the brain, too. Like, the brain is now centrally involved, right? So,
Absolutely.
yeah.
My follow-up was, your sexual pain patients, are these mostly perimenopausal people or do all ages?
No, I have like an 18-year-old, you know, that comes in for the first time having painful sex, can't get over it. You know, I have patients that have unconsummated marriages for 7 or 8 years because they've never been able to get past their pelvic floor issues. I have tons of, you know, 20-plus-year-olds that have this, or they might have persistent genital arousal disorder or some sort of abnormal genital pelvic pain situation in the pelvis. So most of my patients are a mix, actually.
Yeah. Very cool.
And the 4th trimester patients that come in, they can't get better because they're not getting adequate treatment.
Yeah. I think this is going to be an amazing resource for people. I'm so excited to release this episode.
And for people to know that they're not alone, because
Absolutely.
I mean, that's a majority of our listeners are listening to us to just like hear all of this from the first time. Like maybe they don't have access to care to be able to like have this knowledge. So
Yeah, absolutely. And I
exciting.
think the community that you develop. So I love to see these different patient advocacy groups, like Tight Lipped is one, and it's an advocacy group on vulvovaginal pain, right? So it's like people who have painful sex or vestibulodynia or other processes. And it's really been a compelling advocacy group. They're pushing to help teach these like medical students and residents and OBGYN communities. They come to the ACOG meeting, they come to ISHWISH, and they're really pushing because, you know, if you look at the data on how many women get dismissed with vulvovaginal diseases, it's a very large percentage. There was a study that just came out in JAMA that I've talked about with Dr. Kylie Moss, who was really one of the lead investigators here, and she really like had, you know, treated, you know, when you treat a lot of vulvovaginal pain, you hear the same stuff, right? Oh, relax and have a glass of wine. Oh, you know, this is all in your head. I mean, the truth is some of it's in your head, but a lot of it started from something else, right? Like some of it is the fact that you now have this incredible anxiety about having penetrative intercourse, but that came from probably a biologic reason initially, right? It wasn't just, it didn't start that way. For some people who have uncontrolled OCD or anxiety, that can start, you know, to develop, you know, manifest in that form as well, but it's so linked that you can't separate them.
oh yeah,
Absolutely.
we talk about the pain stress cycle all the time.
Oh, right. It's amazing, actually. And that, And I always say, like, if you're not clenching, you're not paying attention these days, 'cause, right? Because the world is on fire. So
I was just talking to my therapist about this. I was like, why am I so like this right now? She's like, well, if you weren't, you might not be human.
Yeah,
like this is just
literally.
like part of life right now.
Right.
We're all stressed all the time.
yeah.
Yeah, not a great place to be at, but
We've talked a lot about sexual pain, but something I really want to talk about is low libido and how you're treated. Actually, I saw on I think it was one of your Instagram posts, and I think you were talking about a medication that you prescribe for low libido, but I think there was something that caught my eye, how you were saying like insurance will cover Viagra and it would be like $5 for someone getting Viagra, but then it would be like $300 for like practically a similar medication.
Right.
But
right. Well, at least it's an FDA approved medication for female sexual dysfunction, right? Which is, we only have 2 right now. So, and, like you can literally get Viagra for that cheap, but, for some women, they can't get this medication. And they work obviously differently, but there are 2 medications that we use in women with hypoactive sexual desire disorder. That means you want to have sex. I will say libido is incredibly complicated for women, right? And this is why the biopsychosocial is so important when it comes to sexual dysfunction, because, you have a midlife woman who she's like, an entrepreneur like us. Like we have, our own thing going, but she might also have kids that are in high school or teenagers. She might also be taking care of sick parents. And then at the same time, she has a spouse that she's managing to keep married or not married, right? She might be going through a divorce. She might be dealing with death in the family, all these things. And she may actually be at the pinnacle of her career or trying to pivot her career. Or maybe she has no career, but is so, entrenched in all her other roles. As caretakers, as women, we carry a lot of burden. I think libido is one of the first things that go, right? Because if you're not sleeping, you're having hot flashes, whatever, you're not going to want to have sex. So I think that that's one thing to remember that is incredibly complicated. Men, of course, like if you're in a heterosexual situation and your spouse or any type of spouse is really problematic, like not giving you the support that you need, or you're not able to communicate with them, then of course that's a whole area of adjustment. But when it comes to the biology of sexual response, we know that there are some hormones that are really important. We call it the sexual tipping point, where your brain can go into like excitatory mode or inhibitory mode. And so the things that can place us into more of an excitatory, like how I say, let's go kind of mode versus like hell no mode, is testosterone, oxytocin, dopamine, and norepinephrine. Those are really prominent hormones and neurotransmitters that can help us in our brain to get us into the mood, right? And then there are things that can inhibit our mood, like serotonin. So that's why when people go on SSRIs for depression, their libido and orgasm function goes out the door as well, right? So that's something that people oftentimes don't even get told that might happen. That they feel, and a lot of people feel dead inside when they don't have a desire anymore, right? Like they used to have this vibrant sexual life and now they don't. And so patients tell me that all the time, like I just, I can see a hot guy or a woman and nothing happens. And so that's when it's really important to look at sleep and lifestyle and, how you're eating and exercising, how you feel about yourself, body image wise, right? So we know body image is very important too, right? Women might be having hair loss, weight gain, some of these other factors, going through cancer treatments. And so we have to look into all of that as well. But the medications that we use, we can replace testosterone for midlife women. So it's a very complicated way that we do that, but we look at your baseline levels, and then, since there's no federally approved testosterone for women, we have to kind of take men's testosterone and titrate it to female dosing to make sure it's safe for women. And then there are 2 FDA approved drugs that are for hypoactive sexual desire disorder, low libido with bother. And so that's like, okay, I've treated your painful sex, I've done all these other things, still have no desire, right? Because obviously if you're in pain with sex, you're not going to want to do it.
No,
either,
yeah.
right? So you have to kind of get past those hurdles. But one is called Adi or flibanserin, and that is an FDA-approved medication that you take every day. And so you take it right before you go to sleep at night, and it modulates your norepinephrine and dopamine and kind of increases that and decreases your serotonin to help. And about 60% of women, it's really effective in improving their desire, arousal, and orgasm function. So we can give that a try if your insurance will cover it. Otherwise, I directly dispense it now in my office too for the patients who don't get coverage.
Okay.
And then I call it the date night drug or the on-demand drug, which is called Vyleesi or bremelanotide, and it's an auto-injector that you use 45 minutes before intended intercourse. And it kind of gives you like a little dopamine hit, right? Like you're trying to get like a little rise in dopamine. You have to get past some of the side effects, which can be, nausea or flushing and some of that stuff. But for patients that it works for, they love it. And we can use it up to 8 times in a month. And yeah, I think a lot of patients will find that it helps their overall, again, about 60% of the time will help their overall sexual function. And so if you're going out with your significant other for your weekly date night, or you're going to go on a getaway, like this is the medication that you might use.
Mm-hmm. Very cool.
Yeah.
These are options. Bummer that they are not covered as regularly.
Especially in the peri and postmenopause, because they're FDA approved right now for premenopausal women. So if you are in that other category, it might not get approved for you. Although they're working on a new FDA indication for that. So hopefully that'll change things. But your insurance has to opt into that kind of thing too. So, but in general, insurances won't cover anything that we use off label. So if I use birth control to treat painful periods and tell them it's not for contraception, then it might not cover it, right? But you have to say like it's for contraception, and then it'll cover it, So,
oh yeah, we have the same thing. Like for example, we'll say, and it's still true, right?
Yeah.
Like we'll say we are treating this patient for their ability to tolerate a speculum exam, like for a pap smear, rather than maybe their actual goal is to
have pain-free sex.
But still they do need to tolerate a pap smear,
right?
Like, or a speculum exam. So yeah. We understand that very well.
God, no, it's crazy.
Yeah. From what you describe, because genuinely we haven't heard many providers like talk to this extent about these conditions as you have today. And a lot of our patients will come in with a lot of the symptoms we've talked about, and they'll say that their provider tried to just put them on birth control, which they already want to take, and it's good that they have, but that wasn't helping anything. Yeah. And then their next line of approach was either refer to pelvic floor PT or sometimes nothing. Mm-hmm. So for these patients going in and they're nervous or they've been dismissed before, like what would your advice be to them to like help advocate for themselves?
Yeah, and I think that's the difficult part because, again, so a lot of the data we have on vestibulodynia or painful vestibule, on what we call provoked vestibulodynia. That means you're attempting to have something done, either sex or GYN exam or whatever, and it hurts at the vestibule. Even some of that data that we have on this is maybe in the last, 15 years or so, right? And so if you graduated past that point and you haven't taken an opportunity to do the CMEs around this, then as a doctor, PA, nurse practitioner, whatever, you won't know how to treat this. So a lot of clinicians don't know what they don't know. And so if you're not kind of in that situation, I would say, first of all, in an insurance model, when you see your GYN for an annual exam, it's really just preventative, right? Like, so the first thing you have to say is if you have sexual concerns, you should state, I'm going in for, if you don't want to say sexual pain, say pelvic pain. But it'll automatically put you into a non-preventative category. And so they might allot more time for that. Some practices are able to do that, whereas an annual might get allotted only 15 minutes. If they know that you're coming in and you say, and it might, and I always I tell patients if they're reaching out to me from a different state, why don't you call your GYN and ask them specifically, do you treat this issue? Because if they treat it, you say yes, then you can get in with them, and maybe they will allot maybe 20 minutes or 30 minutes instead of 15, right? So some paradigms in practices are built out that way, where if they know it's more of a complicated GYN issue, they will allot a different amount of time. It always depends on sort of the healthcare system they work for, though. And some people will have like a one day a the week I treat pelvic pain, and so you are in that one day a week. But or sexual pain or menopause management, that they'll only have a half day a week for it. But the problem is then they might have months and months of waiting lists, a wait list. So that might be a problem. So I think that's the first thing, is calling the office to ask if that's something. If you notice that they have it on their website, that usually means they have some interest in it. Every menopause certified clinician isn't actually like savvy on how to treat hormones. So, sometimes word of mouth is really good. Like if your girlfriend got, FDA approved hormones from somebody, that might be a good way to start too. Because I always say, like, it's really up to us to advocate for ourselves. Like, no one is really going to save us in any capacity, right?
Yeah.
So I think that, finding out what they have to offer in their office, asking if they treat these conditions, And then if they do, maybe they allot more time for it. And then coming in with as detailed information about what you're experiencing and a timeline. Sometimes I've had patients email me like their timeline of pain. And so then I go in already understanding some of their story. And so that's also something you can consider doing is like, okay, you have this appointment with this person. I've journaled X, Y, and Z about it. Can you just email it to them so they can either review it before or after the appointment, right?
We've actually suggested that in a previous episode to people to like my chart and be like, these are the topics that I want to cover in this session so that it's like already there for your provider to review. And then it's like you're getting it all in that session. You're not forgetting anything too. But.
And sometimes they'll only take one topic at a time, but the majority of the time, some of these are interlinked. But I think it's important to understand that most insurances will only cover your preventative visit. So a lot of patients try to do it in that visit because they think it'll be covered. But the minute you start talking about a problem, it becomes a problem-based visit. And that always goes towards your deductible, whatever that is. So it's important for you to understand your own insurance because what insurance companies like to do is then go blame the doctor. Like, oh, your doctor didn't code it as a preventative. And so they get really upset with the office staff.
Yep.
And it's a lot of misinformation, but it's really about what your insurance chooses to cover. And if they usually don't cover that, then it will go toward a deductible or some sort of out-of-pocket cost. So that's the unfortunate part.
There's so much nuance.
I mean, that was great advice. I feel like everyone listening like asks us this at some, not everyone, but some people ask us this at some point.
Yeah.
Like, how do I actually bring up these topics to people? So I think that's great advice. How many people do you think are doing this to the extent that you're doing it?
In terms of like sexual medicine expert, there's a lot more menopause trained providers, clinicians now. I think, there's probably over 3,000 now, and there's like, when I started, less than 1,000, right? So, the numbers are increasing for menopause certification, and that just means you've taken a test that shows that like book knowledge about menopause. But in terms of experience, I think more and more people are trying to get experience, and there's a lot of clinicians that are teaching now about it. But in terms of like sexual medicine, there's like one or two more people in Illinois that I know that are pretty good at what they're doing here in terms of GYNs, and more people have come to ISHWISH and have gotten training. So I know more and more are dabbling in it, and I think it really comes down to their ability to see them in the systems that they're in, right? Because I know patients, to be honest, most doctors that you see are not wanting to dismiss you. They're not, but they're actually, and so I feel like especially gynecologists get vilified a lot online. And I get it from a patient perspective. I hear it every day. And of course, the like handful of GYNs that you might have met that would totally dismiss you because they don't, believe in it or whatever. But the large majority of my colleagues really want the ability to treat you for this, but they either lack the knowledge because they didn't get it taught in med school or residency, and they don't have the ability to go to ISHWISH because they don't have enough CME, or they don't have the time off, or they have too many life issues happening to them, or their healthcare system that they work for will not allow them. They won't, because it's not lucrative for them. Yeah. Right? And so I do want to emphasize that. I do see a lot of GYNs get bashed online. And for some of them, sure, just the words that they use were not appropriate. But burnout is real in OBGYN, and the more and more, things that are coming down with legislation that's preventing OBGYNs to practice medicine without the interference of politics is less and less, and so the burnout gets more and more. And so as we just try to do the best for our patients, insurance companies and politicians are telling us not to. It's a system-wide issue. And so I do think that maybe doctors could say things in a better way than just being like, no, you just need to relax or whatever, But I do think the majority of GYNs go into this for a reason that they want to help women and they want to empower women. Absolutely. And they can't in the systems that are in place.
Makes sense. Everything's political.
Trying to provide care with all of these other variables.
Can you imagine? Just think about being in the South right now.
God, no.
I'm from the South, but
I am too.
I'm from here, but I also can imagine providing this care somewhere else right now. We talked about this before, how privileged we are to be in Chicago.
In a blue bubble.
Where we just don't have to worry about this.
We talk about the bubble all the time.
Talk about the bubble all the time. It is wild. Yeah. Since you talked about the healthcare system a bit, I mean, we already said a million things we would change about it, but what would be the first thing you would change about the U.S. healthcare system if you could?
Oh, wow. I mean, I guess I would see if there's a way to take insurance out of the equation, right?
Yeah.
Like, I feel like because of the parameters they have placed that, and it's always like doctors are making X amount because they, blah, blah, blah. But it's really the healthcare corporate systems that are, pocketing everything. And I know OBGYNs have had to close their offices because they can't afford to keep it open anymore because they can't see 40 patients a day and still provide the kind of care that they honestly feel like will help, right? If you're seeing 40 patients a day and you have 5 or 10 minutes with a patient, you're going to burn out. You still have to deal with calling for prior authorizations and all the things that you have to do within a system. But you also, you deplete your own internal self too, right? Like I'm an empath. And so for me, it came down to my empathy gets I absorb a lot of my patients' problems, and so for me I couldn't absorb 20 problems a day.
Yeah.
Like it was not mentally good for me, right? So
Absolutely.
I would come home like a zombie, and my kids and husband would be like, "What's wrong?" And I was like, "Oh my God, people are suffering so much." And, and it's unfortunate, but and I don't. That's the problem that I've experienced myself. It's like I just was drained, listening to all the problems that these patients are suffering with.
Oh, yeah. And there was actually something else that you said that I wanted to comment on too, because you're saying some of these gynecologists aren't learning everything they need to learn to be able to treat these conditions. This is the same thing for pelvic floor PT. So we do not learn anything about pelvic floor.
Right.
With our 3-year doctorate of physical therapy degree, there is maybe like one elective course that you can take, and then maybe like one portion of an exam within I don't know, MSK or something. And it's not like a full course, versus there's like a full peds class that you're taking, obviously maybe 3 sections of ortho, MSK, but pelvic health is not taught. So in order to find a good pelvic floor PT, it makes it really hard. We have to go through multiple certification courses, which can take years and years
and cost lots of
And
money.
then on top of that, clinical expertise. So treating more and more patients with maybe a lower level of expertise, and then gaining that over time.
Right.
So yeah, it's the same. It's the same.
Even us going to school, 4 years apart, my program didn't teach me anything about pelvic floor. I had to do everything post-grad. And Hannah's, because she started an interest group about it, was one of the first to implement pelvic floor stuff at Northwestern. So it's getting there, and we're starting to see it in programs, but it's literally because of PTs saying they have an interest in it.
Absolutely.
And they're just creating the system for it. So that was, I always think that's super cool that you did that.
Yeah.
Thanks.
Well, it's true. And that's what you do, right? We had to go to the OBGYN people and say, this is something that this problem-based learning should be incorporated into the 3rd years, And so it's you want to make sure that another generation of doctors don't go through medical school without any knowledge of this stuff. Yeah. But it's still you're right. You have to have the clinical expertise too, right? So I think it's that just takes time and patience, because you learn so much from every patient.
Absolutely. We talked about a lot of frustrations in this healthcare system and treating, but what would you say the most rewarding part of the work you do is?
Yeah, no, I love the work that I do. My patients bring me energy. I love connecting with them on such a deep level, and I love when they get better. My PT that I work with in my office, she and I give each other a high five every time someone has pain-free sex, and then we do a just have sex dance. That's awesome. But it's so patients will email us, or they'll come to their visit and they'll be pain-free, and it's so rewarding to see that their life becomes more enriched over time, and that you really can, and sometimes it takes time, right? Sometimes it might take a full year for someone to get better. Sometimes it might take a couple months, but it's just such an amazing field, and so rewarding, I think. And so the patients make me want to continue to do this, because it's it's when you get those wins with them. And sometimes you get some backslides and you have to deal with them, but I think it's really just helping them the most that is gratifying.
A lot of providers can relate. It's why we do it at the end of the day.
Exactly.
It's not the easiest industry to be in, right?
Absolutely. Yeah.
That's awesome.
And even the education that we do, right? With I'm going to have you guys on my podcast too, but
yay.
Between all the stuff I think that we do to educate, despite even some trolls that
Oh.
Oh my gosh.
Oh my God. Don't even get us started on the trolls.
The trolls, especially, like, I'm sure you experience it tenfold being, I don't know how many more followers you have, but like, we do not have a big social media following yet. And like, we'll still get these wild hate comments from
Oh my
people that
God.
are like, we're literally, there's nothing to even argue with in our
I know.
video. It's just education.
Someone just commented on one of my videos, like, I had to stop listening to her voice. I just couldn't stand. And then I was like second guessing myself. I was like, I asked my daughter, I was like, do I have a bad voice for podcasting? Like, what's going on?
Oh my God, no.
She was like, please, mama, you're,
I was actually going to say one of the first things I noticed about you was I really like your voice.
Oh my God.
And I could tell you have like, are from the South. I could tell like a little bit,
thank
but
you.
I like your voice.
Like,
Aw.
literally, thank you. That makes me, you just made my day, because literally last night I was like, Jen, do I have a bad voice for podcasting? No. She's like, and this is actually a good experience for my like my 13-year-old, because she's like so afraid to go on social media, because I come on her and tell her like, do you think, and she's like, why are you listening to these people? They're trolls. And I'm
It's hard. It's really hard. We tell ourselves all that. I think we did a full podcast episode on like trying to get past the social media trolls in order to like be like still do what we want to do, which is like advocate, right? Which is one of the things we want to do. And I mean, what was one of the things that it was like a man commented on one of our videos? It was like, if you're listening to these people, like we're all doomed. Like
It was like total airhead blabber.
or something.
my God.
Just it's like, oh, like because we're women talking about like sex. Like, what
Yeah.
do you mean?
Literally.
Like, so I don't know.
Oh, I had a good
man.
one. Was like, oh, I'm surely you could afford to get a better haircut than you have. That's what somebody wrote me.
No, yeah.
Oh my
I
God.
was like, what?
Oh, yeah, like
why
I-
are you commenting on my like whatever?
It's wild.
I remember
know.
I had to text it to my hairstylist, and she was like, "What?" She was so mad.
Literally.
She was like,
People always have something to say.
Yeah, no matter what.
yeah.
You just gotta.
haters gonna hate.
Haters gonna hate.
Yeah.
That's a sign you're doing it right, right?
guess so.
Yeah.
To some degree, depends who's hating. But,
Yeah, exactly.
yeah.
Here's the thing. We all have good haircuts.
Yeah.
And we all have good podcast voices.
Thank you.
That was a good. Here's the thing.
That was a good one, right?
You're on that one.
Heck yeah.
GTFU, right? Can I say that on this podcast?
Oh yeah, you
Okay.
can say. You
Oh, we
can
say a lot.
We say a lot. We're unhinged sometimes.
Okay, all right,
I have
good.
one more question.
Okay, sure.
But then we should probably do more. Here's the thing. That was good. What advice would you give to, let's say, like a 30-year-old woman who is looking to be proactive about her sexual health, but might not have anything like glaring going on? She just kind of doesn't understand where to go from here, like what to expect as she ages with
Yeah.
menstruation symptoms, anything.
I mean, I would say that, like, because there are people that kind of slide through perimenopause without any issue. But I also question some patients, like, what your tolerance has been for pain. I think as a society, we tolerate women's suffering and pain a lot more than we should, right? And so you learn that if you understand someone's cultural background or, you know, what they experience from, like, what they learn from their parents or whatever the case may be. But I always talk to patients, because I do a very thorough pelvic exam. It's just not straight for the pap for me. I'm looking at their vulvar vestibule, their clitoris. I'm looking at their pelvic floor. I'm doing all these tests. I'm asking them, like, do you have vaginal dryness? And some patients will say, oh, I have to use a lot of lubricant, but they don't realize that isn't, it's okay to do, but there might be a reason that you have to use a lot of lubricant. It might not just be that you weren't turned on at that point. You might have dryness because you've been on birth control pills, because you have pelvic floor issues or whatever. And so I think it's just understanding that what's common may not be normal, right? A lot of people complain of sexual pain, and it is common, but it's not normal for you to, like, have pain every time you have sex, right?
Snaps for that.
Yep.
And same, like, you know, low libido is common, but if it doesn't bother you, if you and your significant other, like, both have low libidos and you're fine doing outer course or whatever, right? Like, it's totally fine. But if you're bothered by it and you're like, well, everyone has low libido, it's fine, I'll just suck it up and deal with it. No, you don't have to suck anything up. There are people that will help you with whatever symptoms that you're having, and you just have to find them. So, like, Ishwish for sexual stuff is a really good, www.isswsh.org. You can find people who are interested in sexual medicine, right? They're really empowered by the idea of helping people navigate their sexual health journey. And we know that sexual health is health. That's something we say all the time, because if you look at a man, for instance, who gets erectile dysfunction for the first time at age 40, which, like, 40% of men have erectile dysfunction by age 40, that usually means something's happening on a vascular level, right? Because what is an erection? It's engorgement of that penile tissue. And so if there's something that's preventing your blood flow from opening up, that usually means might be something else is going on. And then maybe they find out they're hypertensive or they're diabetic or they have something happening from a cardiovascular perspective. The same is true for women. If all of a sudden they can't get aroused the same way, or they have clitoral pain or some of these other issues that come up, this might mean something else is happening. And so a lot of your sexual health and your menstrual symptoms speak to something else that might be happening. If you have pain every time you're on the floor in pain every time you have your period and you feel like vomiting, and there's a couple of days like that, or you have to miss school every time you have a period, that's not normal. It might be common in your family because endometriosis does run in families, but it's not normal for you to miss school because you're in such bad pain, right? And so I think that understanding your personal family history and opening the floodgates in your house, if that is something you can do, because a lot of, moms, sisters, or aunts are hush-hush about these issues. But if there's something that you can open up in your house and talk about, then you can that'll be a window into your own health. And then find out what kind of cancers are in your family. Like I have patients who know there's cancers in their family, they've never been tested, and then we test them for genetic conditions and all of a sudden realize that you need to start screening way earlier, Yeah. And so I think that understanding of your history, that understanding of what you think is normal, it might just be common, but you might need to get checked out. And again, some of these things are vital signs, your sexual health, your menstrual cycle.
Absolutely. We talk about that all the time too.
Yeah. And we'll link Ishwish and ishwish.org.
Yes.
In our show notes for you guys.
And the Menopause Society is another link for people who are perimenopausal.
Okay, perfect. Yeah, we'll have all of this linked for you guys in the show notes. Don't worry, guys. We got you.
We got you. We know there's a lot to digest in this episode, so we're going to try to link as much as we can, and this is going to be a resource for so many people that we're like, go listen to this podcast episode and then ask us like where you want to go next from there. And we can refer you out because there were just so many good nuggets.
Thanks so much. I appreciate it.
Yeah.
I love what you guys are doing. I think it's great. And I think the more people that are doing it, the better. Like, some people get weirdly like, oh, that person has one. I'm like, no, it's great. Like different people are listening to different people,
Yeah.
Yeah.
Yeah. Everyone has their own following. Yeah. So it's great to have this, like, just like how we have collaboration, like with treatment, like it's great to have collaboration across.
With educating.
Yeah. Education as well.
Yeah. It's a lot of effort to destigmatize, but not normalize, which is like exactly what we're trying to do with a lot of this. Like help people feel not alone.
Yes.
Like this is something so many people experience and here's what we do about it.
Yes.
Because it's not normal to experience that.
And it helps to make sure our language is the same, like across all fields. So that's great.
Absolutely. All right. Did you think of a here's the thing for us?
We have a little segment where we just say, here's the thing. So we'll just go in like a little circle and it's just like our hot takes from the episode. Okay. If it takes you time to think of it. Okay. Here's the thing. If pelvic floor PT is not working for you, there are other options. Refer to this episode.
Refer to this episode. See the show notes. Here's the thing. You deserve to be taken seriously with comprehensive care, even if you have been told that you don't.
Yes. Here's the thing. I just kind of said this, but here's the thing. If you have some symptoms that a lot of people have, that means it's common. It doesn't mean it's normal.
Yeah. Period.
Yes.
Period. And here's the thing. We all have good podcast voices.
And good hair.
Exactly.
Here's
I'll
the thing,
repeat it
go fuck
again.
yourself.
Literally.
Good
Here's the
podcast
thing. We
voices.
don't listen to trolls.
Yes.
We don't listen to trolls anymore.
Oh my God.
Hannah had to hype up my podcast voice when we first started. I was like, I don't like it at all. And she was like, it's fine. And I was like, okay, great.
No, seriously. So I just as a side, I'm working on this book that I'm going to hopefully.
I was about to ask if you're writing a book.
It's about female sexual dysfunction. So it's called Brown Girl's Disease, ? A Guide to Sexual Health and Empowerment Through a South Asian Lens. So I talk about all types of sexual dysfunction, but give some cultural context and context for women of color, because I think we're always left out of the equation. So
that's something that's lacking.
And, I talk about my own personal journey with vaginismus and other things, which we can talk about another time.
Oh, yeah.
But they had asked me if I want to record my own, like do a audiobook. And I was like, I think I should outsource it because I don't think I have an audiobook voice. But also it takes so many hours, to do an audiobook.
Yeah.
But But now maybe I should say, fuck you, I'm going to do it.
Yeah, just do it. Just do it. Honestly, and the podcasting will help you too. When we first started our podcast, my voice from when I started to now is completely different because you could hear the confidence in my voice change.
Oh, yeah, night and day.
The way I first started, my voice was so high pitched and I was like very careful of everything I was saying. And like now I'm just like, no, I know what I'm doing. I'm confident. Like here I am. And it's my normal voice. Yeah.
Yeah.
No, I think you should.
Voice.
Thank you.
She does. She has a great podcast voice.
We all do.
We all do.
No, you should do your own audiobook. And then you should come on here and we'll definitely talk about your book. We love doing like book reviews and discussing. We'll read it too. And we have a little library out in our clinic that we put all the books
once
out
it's
to.
out. It's probably going to be 6 months out. But
That's perfect timing. Yeah.
That's great. Can you tell our listeners where they can find you on social media or otherwise?
Yes, I'm Gyno Girl on Instagram. I have a podcast called Gyno Girl Presents Sex, Drugs, and Hormones. I'm also on Substack as Dr. Sameena Rahman, the Vagilante Nation.
That's awesome.
I mean, we got our public freaks over here.
That's awesome.
And then I have a website. I'm on the YouTube, Gyno Girl TV, and then my practice is the GYN Sexual Medicine Collective, www.thegsmcollective.com.
Yep.
Perfect.
We'll be linked in show notes. And that clinic is located in West Loop for you guys.
Yeah, a local clinic.
Yes.
Right by us.
Just come here and then come there.
Literally back and forth.
Back and forth. Shuttle back and forth.
All right, guys, make sure you're following us on social media at Pelvic POV. And if you have any questions about today's episode, you can submit those at the link in our bio.
Awesome. At the end of our episode, we always say bye pelvic freaks. So if you would like to do the honors, you can say bye pelvic freaks.
Okay. My best podcast voice.
Oh, yeah.
Bye pelvic freaks.
Yeah.
Bye, Pelvic Freaks.
Bye pelvic freaks.